I'm Deborah Goldman. I'm a pediatric gastroenterologist at the Cleveland Clinic Children's Hospital in Cleveland, Ohio, and I thank you for your invitation today to let me present on a gastroenterologist perspective of children with CDD. I have no disclosures. For those of you who haven't been to Cleveland, Cleveland Clinic is about 2 miles from Lake Erie. We have a very large medical center, a large children's hospital here, and it's a wonderful and beautiful place to work. So I thought I'd start out talking with a case presentation. BL is a 2-year-old female with a history of intractable epilepsy since early infancy, despite several anti-seizure medications. However, her seizures seem to improve on a ketogenic diet. The parents are concerned that she's not able to visually track and has poor eye contact. She is delayed in her neurodevelopment and receives physical therapy for her low muscle tone. She is followed by a multidisciplinary team, which is led by pediatric neurology. Genetic testing has confirmed the diagnosis of CDKL5 deficiency, and she is then referred to numerous team members who provide a multidisciplinary medical care. What I will discuss in the next 25 to 30 minutes is an overview of our approach to these patients at the Cleveland Clinic from a gastroenterologist perspective. Our multidisciplinary team here at the Cleveland Clinic Children's Hospital is composed of several specialists. First and foremost, we have pediatric epilepsy specialist, and here it's Dr. Pastana Knight, who has published on the topic of CDD within our Department of Pediatric Neurology. We also have pediatric physiatrists, pediatric gastroenterologists, pediatric nutrition and dietary therapists. We have occupational physical therapy and also speech therapy available for our patients. As we know, CDKL5 is characterized by early onset of intractable seizures, which is similar to Rett syndrome. Rett syndrome is a mutation of the MECP2 on the X chromosome and is characterized by seizures, motor abnormalities, abnormal hand movements, problems with language, features of autism, and a loss of skills over time. It often presents between 6 to 18 months of age. There are impaired motor skills, and hypotonia is universal. There is a global developmental delay and observed to have often sleep disturbances. They have abnormal muscle tone, bruxism may be present, and visual impairment in CDKL5 is common, with often parents report of lack of tracking and poor eye contact, and gastrointestinal symptoms are very common. CDKL5 disorder is different from Rett syndrome in that it's a mutation in the cycline-dependent kinase-like 5 gene located on the chromosome that results in genetic-based neurodevelopmental disorder. It was first reported in 2003 in 2 girls who had early onset seizures and developmental delays. It occurs more commonly in girls than boys who may also have germline variants. Due to the disruption of the cycline-dependent kinase-like gene, they have clinical features that include early onset seizures that are, as we heard in prior talks and presentations, are very challenging to manage. There's motor impairment with hypotonia, which is universal. They have developmental delays, visual impairments, and may have the hand stereotypic features like we see in Rett syndrome with ringing, clapping, clasping, or mouthing. There are some facial features that may also be present. However, they may be subtle, such as a prominent or broad forehead, a high hairline, relative mid-face hypoplasia. They can have deep set but large appearing eyes, and the eyebrows can be straight and lack an arch, and synophorous, which means one eyebrow going across, can be common, especially in boys. They have full lips, and you can see in the picture shown that they can have an eversion of their lower lip. Interestingly, the facial features do coarsen with age. So I provided you a very brief overview of CDD. Now let's focus on the gastrointestinal issues that we encounter. It's been published in various studies that gastrointestinal health issues are common in children with CDD. Up to 90% of children will report any GI problem. This can include constipation, which is seen between 70 and 80% of children, gastroesophageal reflux, that can be anywhere from 60 to 65%, air swallowing in about a quarter of the patients, and some patients, anywhere between a quarter and 60%, may need a gastrostomy tube to help provide their nutrition. Gastrointestinal manifestations were reported by Mangat in 2016 in a case series that stated that up to 90% of parents reported GI concerns in their children. As you can see, constipation is most common, followed by gastroesophageal reflux, air swallowing, feeding issues, and in many of the patients, they may require a feeding tube, also known as a gastrostomy tube. Most children experience at least one gastrointestinal issue. And as I mentioned, and I'll reiterate, constipation is the most common, followed by gastroesophageal reflux and air swallowing. Children who are over 10 years of age are more likely to have gastrointestinal issues compared with children that are less than 5 years of age. The gastrointestinal symptoms and signs may relate to the mutation in that patients with missense or in-frame mutation have a higher incidence of air swallowing behaviors. The way we approach these patients includes a multidisciplinary approach. They are often seen by with a feeding evaluation. In children not only with CDD, but also other neurological and neuromuscular disorders, they can have oral motor issues, which include abnormal oral muscular tone, strength, and coordination. There has to be a coordination of the tongue, the lips, palate, and mandible for sucking and swallowing to occur. As we know, infants are dependent on suck and swallow. Then they transition to spoon feeding, drinking from a cup, a straw, a sippy cup, and then there's the function of chewing with suckling, munching, and then the mature rotator jaw. And any or all of these may be impaired in children with neuromuscular underlying neurodevelopmental disorders, including CDD. The feeding difficulties are very common in children who are still able to eat and drink by mouth. Most children beyond infancy are often dependent upon families and caregivers for their eating, drinking, and nutritional needs. However, there are a very small percentage who are still able to eat and drink independently, while the majority will need the assistance with finger feeding or spoon feeding. Parents commonly report coughing during eating, and coughing seems to be more common in the younger child, less than 5 years of age, which may signify an underlying swallow dysfunction. When they are seen by our feeding team, our approach takes into account looking at the nutritional status of the child. What are their growth curves for both weight, length, and what their body mass index is, and their weight for length. We also look at the caloric needs for each individual patient. Also, do they have underlying gastrointestinal issues? We do a medical baseline evaluation, including diagnosis, what medications they're on, and past or future surgeries that may be contemplated. And of course, the social, environmental issues are always important. We try to localize within the neurological pathway where the feeding issue may be present. Is it primarily from the brain? Is it the brain stem, peripheral nerve, neuromuscular junction, or is it the muscle itself? It can also be related to decreased appetite, and that perhaps is a reason why the children are not eating, and that can be to a variety of neurological medications that may alter the appetite, and those include topiramate, rufinamide, and methylphenidate. Some medications, however, can increase the appetite, and those include cyproheptadine, valproate, and carbamazepine. Most children with CDD, and studies report that about 80% can still eat and drink orally. However, it does vary considerably. Some other children may need a gastrostomy tube to supplement their nutritional needs and also to help administer medication, give additional feeds if necessary, or to help in venting swallowed air. Up to 20% of children may require these feeding tubes either via a nasogastric tube, a gastrostomy tube, to help provide their ongoing nutritional needs. The need for a feeding tube will next be talked about. There are different types of feeding tubes. We have a nasogastric tube, which is a tube that's inserted through one of the nares, so one of the nasal passages, and goes into the stomach. There is a nasojejunal tube that goes through the nares and goes past the stomach into the small intestine, also known as the jejunum. Then there is a gastrostomy tube, which is a surgically placed tube that is placed in the left upper abdomen. And we also have a jejunostomy tube, which is a surgically placed tube into the small intestine or jejunum. Our clinical assessment of their feeding includes assessing their swallow. 95% of patients with neurologically based difficulty swallowing may aspirate silently. And what that means is they may accidentally have food or liquid go into their lung as opposed to going down the esophagus. They are more likely to aspirate with liquids than solids. Purees are generally the safest and easiest texture for the children to swallow. And we need to consider the entire picture of the patient prior to performing a modified barium swallow with speech therapy. Our assessment of swallowing includes signs and symptoms that parents may report, such as coughing, choking, or sputtering during or after feeds, a wet, junky, or congested breath sounds during or after feeds, chronic wheezing or stridor, oxygen desaturation, or they turn blue during feeds, apnea or bradycardia with feeding, which means decrease in heart rate, or even slowing of the respiration rate, any kind of color change, a chronic fever that we can't find a cause, throat clearing, red or watery eyes during eating or drinking, or gasping for air may all be signs and symptoms of difficulty swallowing. Well, you may ask, why do we place a feeding tube in some of these patients? Well, it's to nourish the child if they're not able to maintain their nutritional status with oral feeds. It may also be indicated to help prevent aspiration if they're drinking or eating purees and coughing that the food or liquid is going down their lung passage instead of into their esophagus. It's also to help decrease orally aversive behavior that they don't want to eat or find it pleasurable. In some patients who have a lot of air swallowing, the G-tube may allow us to vent the stomach and allow it to decompress. It can also help decrease the time caregivers spend feeding the child, and also to help administer the numerous medications that they require. Our indications to place an enteral feeding tube is really a joint decision that is made with the family, the caregivers, and our multidisciplinary team. It includes, as I mentioned, if children are having inadequate intake, they're unable to coordinate their swallowing. This may be seen especially in premature infants, patients with oropharyngeal disease, or laryngotracheal abnormalities. Sometimes we have to place feeding tubes in children who have esophageal disorders. And in the case of CDD, where there's a central nervous system disorder, gastrostomy tubes or enteral feeding tubes are often indicated if they have underlying degenerative neurological disorder, and encephalopathy, severe cerebral palsy, or a severe oral or food aversion. Well, as I mentioned, we have various feeding tubes available. When do we place it? Which one do we place, and why? We have our nasogastric tube that goes from the nose to the stomach, a nasojejunal tube that goes from the nose into the small intestine, a gastrostomy tube that goes directly into the stomach, a gastrojejunal tube that goes from the stomach into the small intestine, and then a jejunostomy tube that goes directly into the small intestine. Our indications for enteral tube feedings may be that the child is requiring a specialized formula. And as we know, CDD patients may be on a ketogenic diet to help control seizures. These diets may not be palatable for the child to take, and therefore a gastrostomy tube may be indicated. We also place enteral feeding tubes in children who have hypermetabolic states or malabsorption, such as patients who have congenital heart disease, cystic fibrosis, short bowel syndrome, and inflammatory bowel disease. So it isn't just patients with underlying neurological disorders who need these enteral tube feeds. It's also helpful if medications have to be provided. And in the case of CDD patients who have a lot of air swallowing, it may help for stomach venting. The decision is based on a multidisciplinary approach. We can either place a nasogastric or nasojejunal feed. Often this is a first-line strategy. However, it is only used short-term temporary measure, in general 4 to 8 weeks. Having the tube in the nose can lead to nasal ulceration, inflammation of the sinuses, and could potentially, if it's malpositioned, they can have an aspiration pneumonia. It does require frequent replacement, especially in young children. The tube in general is taped to the side of the face. A gastrostomy tube, a gastrojejunostomy tube, or jejunostomy tube are really indicated for feedings that are indicated over the long term for more than 2 months, or if there is any reason why a nasogastric or nasojejunal tube cannot be placed. About 25% of children with CDD will need a gastrostomy or a jejunostomy tube placed. It seems that more boys are dependent upon this than girls. However, no difference has been observed in the mutational groups. The indications in CDD include feeding difficulties, poor weight gain, difficulty with administering medications, poor general health, and concern that the children are aspirating with feeds. This is just a picture of what a nasogastric tube looks like. And you can see the tube goes from the nose and it goes down the esophagus into the stomach. And then the bag is held up and the feeding is delivered via bolus feed. This is a gastrostomy tube. And you can see in the picture, the boy has a little button that's surgically placed into his stomach. It goes through the abdominal wall, is placed into the stomach as a low profile device, and then it's just hooked up when the feeding needs to be started. Our options for gastrostomy tube placement include surgical, which is open or done through a laparoscope. And we can consider this in patients with prior abdominal surgery or those patients who have a ventricular peritoneal shunt. They can also be placed through an endoscope or what's called a PEG, and it's done endoscopically, and it's less invasive than a surgically placed gastrostomy. Radiologists can also place what's called a percutaneous radiologic gastrostomy tube. So we do have some options available. Moving on to a next topic, which is frequently seen in our CDD population, is constipation. It appears to be more common. It's common in boys and girls, however, slightly more common in boys. And it is defined as pebble-like stools or stool passage less than 3 times a week and or a large stool mass palpable on abdominal exam. It most likely relates to a slow transit time of the intestinal content and the stool that results most likely from an autonomic disturbance. It is very common in children with underlying motor or neurological disabilities, and especially in those who are tube fed, and it may also relate to medication side effects. We often treat the constipation with laxatives or stool softening agents, such as Miralax. And it may be difficult to treat, and we need to make sure that the laxative dose is adequate, that there's enough free water in the diet, and also the fiber content in the diet is also important with soluble fiber. You want to make sure that the child is getting adequate laxative agents to achieve 1 soft stool either daily or every other day. Just a few slides about gastroesophageal reflux. Gastroesophageal reflux, we make a diagnosis based on their signs and symptoms. On the left, you can see what an upper GI series is. All this shows the medical provider is the anatomy of the GI tract. It does not diagnose gastroesophageal reflux. There is a test called a pH impedance, where a probe is placed from the nose down the esophagus, and we can measure how much reflux is present. However, gastroesophageal reflux is a clinical diagnosis, and really invasive testing, such as a pH probe or an endoscopy, is not indicated. We can do a trial of antacid medications if you suspect acid reflux. We have H2 receptor antagonists, such as famotidine. They can be taken orally or through a G-tube as a liquid or an oral dissolvable tablet. We also have a class of medications called proton pump inhibitors that can be taken orally as a liquid or an oral dissolvable tablet. Please make sure that there is no drug-drug interaction, especially with anticonvulsants. And we need to make sure that we monitor these children, especially if they're on long-term use with proton pump inhibitors. Nutrition is also very important in these children. We look at their dietary requirements. They may also need special formulas, whether they're milk-based, milk and soy-free, or plant-based formulas. And then there are some children who require ketogenic diets that may help with seizures, or a blended diet that can be provided through a gastrostomy tube. And we work very closely with our nutritional services. In wrapping up and ending, I wanted to share some thoughts I have and some future thoughts about directions for the brain-gut interaction that we see not only in children with CDD, but also other underlying neurological disorders. Gastrointestinal symptoms are very, very common, and we really need a better understanding of this interaction in children with CDD and other neurodevelopmental diseases. We need to address gaps in our knowledge regarding changes in the enteric sensory processes and the structure and function of what's called the enteric nervous system, or all the nerves that line the GI tract. Possibly assess the potential, the GI tract as a source of a biomarker, and possibly new therapeutic targets to help our CDD patients. And we need to have a crosstalk between brain-gut investigators, gastroenterologists, neurologists, epileptologists, to help facilitate collaborative opportunities. We need to define areas of common interest in brain-gut research and research at various research sites. And in the United States, we have the National Institute of Health, the National Institute of Digestive and its digestion, diabetes, and kidney disease that are so important that we collaborate with. The questions to answer: is there pathology in the enteric nervous system that's related to the cause, or is it the result of the CNS pathology? Are the GI symptoms due to an early brain or early gut effects? And how does the gut dysfunction inform us of possible changes in the enteric nervous system or its circuitry, what the wiring is? And what are the mechanisms of these changes? Do patients with CDD have different gut sensations? And what about other cell types in the GI tract, such as glial cells, the immune cells, or the interstitial cells of Cajal? Are there gender differences in the gut symptoms? And what is the minimum GI testing that needs to be performed in these children? Are there other areas outside of the luminal GI tract, such as the pancreas or the bladder, which are also affected? Do children have altered sensation? And what is the future for GI-focused interventions and possible potential GI therapeutic targets?